Hello, I'm Dr. Yvette Rubidoux, and I'm the Director of the Policy Research Center at the National Congress of American Indians. Welcome to our monthly webinar series. Today, we will focus on diabetes translation and the application of dissemination and implementation research. This webinar is a resource provided through our partnership with the Center for Diabetes Translation Research at Washington University in St. Louis. Last month, we had a very successful webinar featuring what the Indian Health Service is doing to address the opioid epidemic through the activities of its HOPE Committee. If you missed that webinar, the recording's available on our NCAA YouTube page or on our website, www.ncai.org/PRC under webinars. We're so glad you joined us today and encourage you to watch for our monthly webinars on the fourth Thursday of the month that focus on how data informs policy and will feature a variety of topics and various guest speakers from time to time. Next month, it might be the last Thursday of the month, and we'll send out an announcement soon. So here's an overview of today's agenda. I'm Dr. Yvette Rubidoux, and I just provided a welcome. Our speaker today is Dr. Stephanie Mazzucca with the Prevention Research Center in the Brown School at Washington University in St. Louis. And we will reserve time for questions at the end. Before we get started, however, I'm going to review a few housekeeping items and let you know how you can participate in today's web event. So this is a depiction of the GoToWebinar attendee interface, and it's made up of two parts: the viewer window on the left, which displays the presentations, and the control panel on the right. I'll quickly navigate how to use the control panel so you can readily participate in today's web event. By clicking the orange arrow, you can open and close your control panel. And here's what you'll find, all the information about your audio connection. We recommend dialing in via phone rather than the computer, as it tends to limit feedback. To dial in, you will find the number and access code here, along with your unique audio PIN. As you can see, all attendees are currently muted in listen-only mode. At the end of the presentation, we will open up for questions. At this time, please submit your questions via the question pane. As a reminder, today's webinar is being recorded. After the event, you will receive an email with a link to a short evaluation, as well as the recording, which will also be available on our NCAI YouTube page and our PRC website. At this juncture, I'm happy to introduce Dr. Stephanie Mazzucca from the Prevention Research Center in the Brown School at Washington University in St. Louis. Welcome, Dr. Mazzucca.
Thank you so much. I'm so happy to join your webinar today to talk a little bit about translating diabetes research into practice in some of the communities that you're working in. And what I will do today on the next slide is go through a little bit about, one second. Okay, sorry about that. I'll go through a little bit about what is DNI research, how it differs from other phases of research, such as efficacy or effectiveness. I'll go through some of the core components of DNI research. As it turns out, I'm hopeful that today some light bulbs will go off and you'll say, wow, I was actually doing this already and I just didn't call it that, because a lot of these principles are the same and will complement a lot of what you're already doing with the great work that you're doing in your communities. I'll then go through a quick example study of DNI research with a group in Canada. It doesn't exactly map onto diabetes research, but I think it's really interesting to show how a group was successful in taking an evidence-based intervention and putting it into the Alexis Nakota Sioux Nation in Canada. Last, I'll go through some DNI resources with you, and I won't spend too much time on this, but it's really a good repository of information so that when you go back to your work and next week you can't remember what I said about something or another, or you want to learn more, these are really good jumping off points for you to be able to continue your learning about dissemination and implementation research. Next slide, please. So I keep saying dissemination and implementation research. Well, what do I mean by that? Here in the US, we use these terms dissemination and implementation to refer to two aspects of research that are kind of along a continuum, but the NIH defines them as separate research activities. And with dissemination, we're focused on the push of information or evidence-based interventions from researchers out into the real world, or the public health or clinical practice world. And with implementation research, we're focused on how communities, settings, different organizations take these evidence-based interventions, or EBIs as I'll refer to them today, and put them into practice in their clinical and community settings. So it's, again, the spectrum. Usually they go hand in hand, but the NIH defines them a little bit distinctly. Next slide. In some of the work that you'll see, D&I has a couple other terms. So knowledge exchange, transfer, or translation, implementation science broadly, research utilization, and scale up. These terms all mean the same sort of thing. They're all referring to the big umbrella of dissemination and implementation research or science, but different countries and different organizations use different terms. So we're all on the same page. These all refer to the same sorts of things. Next slide. And kind of the cornerstone of D&I research is a lot of times we as researchers, and I'm certainly guilty of this myself, we assume if we build the perfect intervention, everyone will want to use it, it will spread like wildfire, and it will make everyone's health perfectly better automatically. And if we think back to the movie Field of Dreams, the mantra was, if you build it, they will come. However, we know from lots of practice and lots of scenarios that this isn't actually the case, that just because you have a good intervention doesn't mean that it gets out into the general public, into different communities that really need our work. So we kind of refer to this, if you build it, they might not actually come. And it's kind of the impetus for D&I research that can more efficiently translate what we do as researchers paired along with you as practitioners to improve public health in your communities. Next slide. And we know that we have some good evidence to show that if we build it, they might not necessarily come. We have good evidence that shows that specifically within clinical settings, patients aren't necessarily getting treatments that they should be getting. And in fact, sometimes they're even getting treatments that they don't need or that are potentially harmful to them or perhaps to the financial cause of a hospital or clinical setting. So implementation of what we know as researchers into practice is really challenging. And so we have this thing called the no-do gap. And the hope for dissemination and implementation research is that we can bridge this gap and more effectively translate research into practice. Next slide. And this is just a little bit of a cartoon to remind us that we have both the supply and demand problem. We need to be supplying evidence-based interventions that work with communities, and people actually have to want what we have to give. So it's kind of, we need to think about both what we're putting out as research and as evidence-based interventions, and also what's relevant to practitioners. Next slide. So in the definition of implementation or dissemination and implementation research, there's this focus on the word evidence. And I just wanted to spend a minute thinking about what do we actually mean by evidence that we're translating here. So next slide. Most people that I work with, and you can click on the next one as well, will think about some scientific reviews, so systematic reviews of lots of different studies. Next, you can click, actually, that you can click all the way through until the big arrow shows up on the right. So we can think about scientific literature, systematic reviews. We can think about individual studies that might be testing the effect of one intervention in particular. We can also think about program evaluation data, so data that's coming more from communities themselves. And those are all some more quantitative measures. We can also think about qualitative data as a source of evidence. So this could be coming from community members or other stakeholders that provides really rich context as to the how or why something happens, not just the what or how much that we get from quantitative data. And then we can also use other sources such as media, so how acceptable an intervention is within a particular community as evidenced by the coverage that it's getting in newspapers, or also word of mouth. You hear, in your communities what works and what doesn't, and that is a source of evidence. And these range in terms of how objective or subjective they are. You can click twice more for that. And one more time. It's a very complicated slide. But we can understand that these are all different sources of evidence that are important, and how we're categorizing these is really in the eye of the beholder, but we need to remember that they're all different and important sources of evidence for us. Next slide. And so thinking about these different pieces of evidence, next slide, we can think about how they all come together in order to facilitate decision making. So we have really good research evidence that an intervention works. And we have really good practitioner experience from you all in the community to know that this would be a particularly good fit for your community. And then we're also wanting to take into consideration the population of interest and what their characteristics are, what they need, what their values are and preferences, and think about all of these sorts of things happening within the broader environmental and organizational context where these interventions will be delivered. And all of those come together to inform decision making. So this is just to show that there are many different things that play into our decision to implement or to translate an intervention into a new community. Next slide. And when I say translating research into practice or translating an intervention into a community, I'm primarily talking about what we call T3 and T4 translation. So this is a slide from Rebecca Lobb that was in the Annual Review of Public Health not too long ago. And it walks you through how we get all the way from things like lab-based studies or mouse studies in basic science run by basic scientists in the top left-hand corner. And at each step, we translate that information to a new group. The green boxes are scientists or researchers. And at each of the blue translation steps, we have stakeholders that are engaged along the way as we go all the way around the circle up to bigger decision makers in public health, like the government, things like that, so that we can ultimately get what we learn along the way as researchers and we can implement it into practice. And I think it's interesting the way that this figure is laid out. Each of these different translation steps, or the blue arrows, there are stakeholders that are relevant to each part of that process as we translate something from a lab into a small behavioral trial or a small community-based trial up to kind of a bigger, multi-site, larger scale trial. And we need to be thinking about these stakeholders all along the way, even when we're thinking about, developing a new idea, right? We need to be thinking about all of these different stakeholders that inform translation along that path. Next slide. So I'll start to distinguish implementation research from other aspects of research in using this figure. So what we have here is the what of what we're implementing. So QIs are quality improvement efforts, and ESTs are empirically supported treatments. And really this comes from clinical work, less so on the public health side of things. Essentially what we're talking about here is an evidence-based intervention, whatever that looks like, whether it's a program, a practice, or a policy, anything like that. And then usually what we do when we test the effect of an intervention, we're testing the effect of that intervention on something like individuals' weight loss or dietary intake or physical activity. There are patient outcomes all the way at the end. So very distal outcomes. Click to the next. And this is what we call the usual area of research. And if we click one more time, we know that in actuality, when we're moving an intervention to that we already know works into a new setting, it's going to need, it doesn't just happen automatically. So we refer to implementation strategies as the way that an evidence-based intervention is implemented within a new setting or within a different setting. Click to the next two, please. And within implementation research, we know that things like how feasible an intervention is in a new setting, how acceptable it is to its recipients, how costly it is, those are all important outcomes of the implementation process. So we don't necessarily need to always gather information about individual patients or community members, but even something as more proximal as how feasible it is an important outcome of the implementation research process. And these in turn affect things like how efficient or how timely an intervention is implemented into a new setting, and those all can in turn impact that very first outcome that we were looking at, something like the patient behavioral outcomes. Next. And so these are kind of these things in the middle, the implementation strategies, outcomes, and what are called service outcomes, primarily in a more clinical setting, are the core of implementation science. Next slide, please. So thinking more about what I mean by implementation strategies, you can click to the next. Here we're thinking about things like providing technical assistance, adapting or tailoring, and using perhaps financial strategies, so things like having an intervention covered by Medicaid or Medicare. That would be an implementation strategy to improve the uptake of an intervention or a clinical service within a community. Next slide, please. And if we think a little bit more about those implementation outcomes, next slide. Here we're thinking about things like how acceptable it is to a new community, how well it's adopted, how well it's implemented with fidelity, which essentially means how well it's implemented according to how it was intended to be. So if we have an intervention that's been developed and has an evidence base behind it, is it implemented according to how it was originally developed? And these are kind of these more proximal outcomes that you don't have to go all the way out to what changes are in individuals, but they're more organizational level outcomes that are crucial to understanding the implementation process. Next slide, please. So putting all of these kind of new mumbo jumbo words into a little more context for something that might be more familiar for you. This will look a little bit, if you know anything about the special diabetes program, which I'm sure most of you do, we can kind of take a similar approach with this. So say you wanted to implement the diabetes prevention program into a new setting. So that's your evidence-based intervention, because we know from a whole host of studies that that has worked in the past. But when we're translating it into perhaps one of your American Indian and Alaska Native communities, you know that it's not just going to fit one-to-one. And I'm sure you all have many examples of how that has failed horribly in the past. So what we do is we kind of take a step back and think, what are the implementation strategies that we need to be able to implement the diabetes prevention program in our community? So perhaps we would do things like conducting a needs assessment, promoting adaptability, so kind of taking the core components of diabetes prevention programs, but tweaking them a little bit so they fit better within our community. And then perhaps in terms of the folks who would be implementing the program or leading the educational sessions that are a part of the diabetes prevention program, perhaps giving them some audit and feedback so that they can understand how well they're implementing the program and what changes they need to make at the interventionist level. And maybe we would be interested in something like how well it was implemented with Fidelity and how costly it was per participant. And then later down the road, we can also consider important outcomes such as caloric intake or weight loss that we know are important outcomes of the diabetes prevention program. So we can kind of see how each step of the implementation process fits more within our public health community-based approach. Next slide, please. I won't spend too much time with this, but I just did want to point out that D&I, which appears in the yellow cube towards the right, is seen as the last stage of research, all the way from efficacy, so understanding could a program work in ideal conditions, more in sort of a highly controlled setting. Then we go to effectiveness studies, Does a program work in real world settings where it's implemented by real community members as opposed to, I say real as opposed to the quote unquote fake researchers, which is not really the right term, but does a program work in the real world essentially? Then we move into D&I at that last phase, and we're trying to understand there how a program works and how a program is adopted, implemented, and sustained over the longer period of time. And next on this slide. And here we can see that there are a couple different questions that we would be asking within dissemination and implementation, and these primarily relate to the differences between choosing an evidence-based intervention, what is needed for it to be implemented, and then what is needed for it to be sustained or maintained over a longer period of time. Next slide. And one thing that I think is important and not always thought about in a careful manner is the difference and the trade-offs between fidelity and adaptation. So like I mentioned a little bit ago, fidelity is how well an intervention is delivered as it was planned or as it has been tested in the past. But I also said that adaptations are needed when you're translating an evidence-based intervention into a new community. So those two things kind of seem counterintuitive or seem like they can't coexist at the same time. And so we need to strike a balance between the two of these because there should be core components of whatever intervention you're adapting or whatever intervention you're translating that really can't be changed. So you can't just cut off half of the sessions of an intervention and expect to have the same sort of outcomes. But perhaps you could deliver them in a slightly different setting, maybe in a different, with a little bit of a different model in terms of how large the groups are, how frequently they meet. Maybe you could add on a couple little things. And those would be adaptations that we would need to think about at the beginning of our planning period or at the beginning when we're deciding to implement so that we're able to think through those adaptations and carefully plan for and capture what's happening within them. The trick with this is that when you make adaptations on the fly, so we call those unplanned adaptations, we tend to not account for them, and we don't really understand what effect they could have on the impact of the evidence-based intervention. And more often than not, they tend to decrease the impact of the intervention. So you kind of go through this process of adapting and making these changes, and then you don't even get the outcome that you were hoping for. And as we're thinking through planning for adaptations to be made, there are lots of frameworks that are available. There was a recent review of different frameworks for translating or for adapting interventions that was just published a couple weeks ago. And essentially these provide a series of frameworks that you could use depending on the nuances of your communities or of your substantive areas. But essentially they kind of cover the same sorts of things. You want to take some assessment of the community and the evidence-based interventions that are available to you. You then find what is the right EBI or the best EBI available to your setting. And then you want to make sure that you're consulting with experts and stakeholders, both from a research and a practitioner standpoint. So this is where I think the beauty of D&I is that it requires input from researchers and practitioners all along the way in order to be successful. With this consultation process, you can decide upon what adaptations you need, make those adaptations, and then you don't just go right in and fully implement the new intervention or the adapted intervention. You want to make sure that you allow for time to test these adaptations and see, are these the right adaptations? Maybe we don't need them. Maybe we need some other things. And then you can go ahead and implement the adapted evidence-based intervention, of course, evaluating whatever outcomes are relevant to you all in your communities. Next slide. Now I'll spend a little bit of time going through an example of health promotion in Canada with the Alexis Nakota Sioux Nation. And this comes from a paper that was, the citation is at the bottom of this slide if you would like to refer to that for more information. Next slide. And so a couple different things that I want to point out with this example is that this is a really good example of how academics and community members worked together to, over the course of many years, improve public health within their communities. So how this unfolded was academics approached some members of the nation, and they created a partnership broadly to improve children's educational and behavioral outcomes. They didn't necessarily have an agenda going in saying, we want to do this intervention with your group, will you work with us? They kind of developed it more informally at first, actually, and did some kind of groundwork and gathered some assessments of children. And through that work, they discovered that many children had fetal alcohol spectrum disorder. So based on these initial assessments, that's how the partnership identified that they wanted a solution to this problem. So it was kind of a group decision, and they used both the community's perspective and the data that the researchers had gathered to inform what and how they wanted to tackle in terms of their public health problem. And they wanted a solution that would fix the root cause of this. So thinking about not even when a mom gets pregnant, but taking a step back and catching kids before they even start to drink or to use tobacco products. So they wanted to really get at that kind of first line of prevention standpoint. And they used a community-based participatory research approach to go through this identification and application program or process. And I think that this was interesting. I don't know much about how Canada's research mechanisms operate, but there is this thing called the Canada Tri-Council Policy Statement, and it clearly lays out the best practices for engaging with research in all different sorts of communities. Specifically thinking about in Canada, there's a whole section about First Nations research, and it lays out the importance and the steps needed to be able to conduct CBPR within these communities. And I thought that that was really nice, because having a mandate from the feds, who are providing the funding for a lot of this research, on what they expect in terms of high quality, engaged research with communities is really a nice tone to set from the top down. So I thought that was an interesting spin to all of this that they highlighted within this work. Next slide. So in order to figure out what intervention they wanted to focus on in order to prevent eventually fetal alcohol syndrome, they identified through a literature review this thing called the Life Skills Training Program, and it had been developed and tested in a whole host of different school settings, some different characteristics in terms of urban and rural, and they felt like they had a pretty good representation of different sorts of communities, that this might be the evidence-based intervention for them. They also thought that it was interesting and a good fit for them because it was delivered in the classroom, and I guess within this community that was a really good setting where it was easy to kind of leverage what people were already doing in this community to just build on top of that with this program. And the program wasn't just focused on drug resistance. It actually includes quite a bit about personal self-management and general social skills. So it's a little bit broader than just thinking about things from a traditional health perspective, which was appealing to the community members. And just a note about this program, it is designed for both elementary and middle schools, and it goes through the academic year for each grades 3 through 8. There's a couple differences with how frequently it's implemented, but essentially grades 3 and 6 are the heavy hitter years, and then you have booster sessions through grades 4, 5, 7, and 8. And in order to make all of this happen, they formed the Alexis Working Committee, and this was a group of community members, both parents, I think there were a couple elders on the committee as well as researchers, and they worked together to oversee the project in terms of its administration and the implementation within the community. And then at the end, interpretation and presentation of results. So next slide, please. The working group or the partnership created 4 main objectives that they wanted to achieve with this partnership between the nation and the researchers. And the first of which they wanted to do, they wanted to review the programs and the cultural adaptation of the LST programs. And to do this, they created an adaptation committee. which again was comprised of a whole host of different perspectives. And this was primarily to make sure that whatever adaptations would be happening within this program were acceptable to the students, parents, and the community at large, without sacrificing the main goal of the program to improve children's behaviors. And a couple of things that came out of this consideration of this program and how it might fit within this community one of them related to the way that self-esteem was talked about within the program. So within this community, it seemed that there was a real strong importance of history and culture as it relates to the self-esteem and the identity of young people. And they thought that it was important to incorporate that and not just self-esteem as we might think about it in a more traditional American or a Western sense otherwise. Another adaptation that they did was to design a module that specifically distinguished tobacco that was used for important ceremonial purposes from what they called poison tobacco, so things like smoking cigarettes. And this was to distinguish things that were important within the community and culturally accepted and probably don't have as many negative health outcomes as opposed to smoking cigarettes, which we have such strong evidence that it relates to a lot of poor health outcomes. So then after all of this adaptation, they went through a couple different steps to deliver their adapted program, which they renamed in their native language. They did both a feasibility test for 1 year to see if their adaptations were on point, and then they went into a full-scale study. And they still along the way had to make modifications with every step that they took. So I think it's just important to note that flexibility is so important. Next slide, please. With the objectives, the third and fourth objectives that they were focused on, these were really to understand the impact of this intervention within the community, both at the student level and within the community at large. So that fourth objective is really focused on essentially what we would go back to at the beginning of the presentation, those implementation outcomes, so acceptability and feasibility within that community. And for both of these objectives, they used a variety of research or of resources, both qualitative and quantitative. And the qualitative measures included some focus groups with both parents and other stakeholders within the communities, as well as elders. And then they did follow-up interviews with the elders in the nation at the end of the project. The quantitative measures were mostly focused on changes in student knowledge, and those had been validated within as part of other studies that were used to evaluate the LST program, but they were able to modify them a little bit to fit better within this community. For example, they didn't ask specifically about drinking or drug use because it was deemed culturally inappropriate. So they were able to take validated measures that had strong research evidence behind them and put them into place in their new community. Next slide, please. And I'll really quickly hit on their results. Within both their feasibility and their full-scale study, they showed positive changes in both student outcomes and in the way that the intervention was considered or how acceptable it was within the community. This was shown as part of both their quantitative and qualitative research. And at the end of this, I think one of the most interesting marks of acceptability and fit within the community is that the nation's leaders actually made a formal commitment to continue implementing the program, even when all the research dollars had gone away, even when they still had this partnership with the university, but it was at the end of their project when a lot of times in other situations, it would just, it would end and that would be the end of it. And they even wanted to expand it to include a parent component so that it wasn't just focused on the students themselves. Okay, next, please. So to wrap up on this part of the presentation, know that D&I is a rapidly growing area of research, and its primary goal is to encourage fast, efficient, effective translation of research into practice. It's similar but distinct from other phases of research, And it should actually be considered all along the way. So even when we're thinking about could a program work in the most ideal of conditions, we want to make sure that we're using information from practitioners and from communities to make sure that, is this even actually a good question to be asking? Could it ever be disseminated or implemented in a real world setting? And if not, we probably shouldn't waste our time researching it. And like I mentioned before, D&I really works best with the input of a whole host of different perspectives, and it really enriches the quality and effectiveness of our research. And as we saw within the example that I quickly walked you through from Canada, adapting an intervention to a new community takes a lot of time. I think it took them 3 or 4 years even to get to the point where they were testing an intervention. And you just have to have patience and lots of open dialogue about what works. However, adaptation is important because it can make an intervention fit within your specific community and potentially increase its effectiveness. And like I mentioned, it should be planned and not done at the expense of of those core components of the intervention or its fidelity. So next slide, please. I'll quickly buzz through these resources that I have for you. Next slide. One that I did want to make sure that I touched on was what is listed as the DIRC toolkits. So this is a core of D&I researchers here at WashU that help other researchers who are interested in doing dissemination or implementation research but don't necessarily have formal training. They have different toolkits that walk you through all of the different stages of dissemination and implementation research, and those are listed on this slide. They're just really helpful, very user-friendly resources for you to kind of get your head around what all is encompassed within D&I research. I've presented a couple other training or webinar presentations here. On the next slide, I have a couple resources for where you can find lists of measures. So we know that measuring what we do is important. And here within some of these resources are measures that others have used so that you don't have to reinvent the wheel if you're looking for a different sort of measure to use in your research. Next slide. We also have a few textbooks within the D&I field and also within health behavior in general. So the seminal textbook is the one on the left. There is a new edition that just came out last December, and that's by folks here at WashU. And then also a couple other spins on D&I research. And then the health behavior book on the right is really a nice overview of health behavior and its theory and research behind it and how to implement it into practice. Next slide. We also have a couple conferences that are related to D&I research. This one is from last year. I couldn't find the information for the one this year, but it will probably be around the same time in December in the DC area. And this is a whole conference just dedicated to D&I research, which is really a nice place to learn. Next slide. There is also a website that you can search to find what would be a potentially good model, so a theory or a framework that would fit your dissemination or implementation efforts. So it'll walk you through a series of questions in terms of what the specifics of your research is, and it identifies different frameworks or theories that have been used by others that might fit what you're doing. Next slide. And for the super curious, we even have some training opportunities where you can go and spend dedicated time developing your D&I training skills. And there are 2 of them within the US. And I did find this one from the University of British Columbia that has a whole institute that's dedicated to Indigenous public health training, which I thought was really interesting. And I don't know any other resources like that within the US. I'm happy to hear if there are, and I just missed them. But I thought that was really interesting that they have a whole section of their training institute dedicated to that. Next slide. Last, we have NIH funding opportunities, And these are 3 specific mechanisms, all dedicated to dissemination and implementation research. And there is a standing study section, so this means that there is a whole group and a whole pot of money dedicated specifically to D&I research. Next slide, please. I'd just like to take a moment to acknowledge my colleagues here at WashU for their help developing this presentation. Many of their slides were incorporated into this one. For the PRC for hosting me as a postdoctoral researcher here at WashU, and for the CDTR for putting this all together. Next slide, please. I'd also like to thank you for your time today in participating in this webinar, and I will now take any questions you have.
Great. Thank you, Dr. Mazzucca. That was really helpful and interesting information. I think, you know, dissemination, implementation is something that we do a lot in Native communities. We take evidence-based interventions and implement them to benefit a variety of different, very diverse communities. And the information you've shared today really helps us think about how we can frame that from a sort of a research frame, and to think about all the resources and potential funding that's out there to help us with these kinds of activities. So I really appreciate your helping us understand some of the basics of this area. I'd like to invite the audience to ask questions. You can actually type your questions into the question pane, and we will ask those questions. Feel free, any questions are welcome. And you know, one question I have while we wait for some questions to be typed in is, you know, with a special diabetes program for Indians, it's a congressionally funded grant program that funds IHS tribal and urban Indian health programs to implement activities to prevent and treat diabetes. In 2004, we got an increase in funding, and a part of it was to be used to translate the diabetes prevention program into 36 diverse, you know, American Indian Alaska Native communities. And, you know, as I think back on what we did, it sounds an awfully lot like this, you know, sort of dissemination and implementation with an evaluation. And it seems like, you know, back then I don't really remember people calling it dissemination and implementation research or evaluation. How long has this sort of framework been around?
Yeah, so I think that that's interesting, because I think you just missed the cutoff of someone being, you know, tapping you on the shoulder and saying, hey, I think that this is what you're doing. So I think the roots actually go back. It's a pretty interesting field because it comes from, its main roots are actually from agricultural economics, funny enough, and it kind of has built all along the way from medicine and from social work, from a little bit from business and economics. It kind of comes from, you know, really anything that you can think of. Organizational behavior, it picks up a lot of different things just besides like public health and clinical services. So I always thought that that was something that was really interesting about D&I research. It probably, I guess, so the new D&I book came out in 2000, so it came out last year in 2017, and I think it was let's see, was it, I actually can't remember. I think, but really traditionally when we think about this, it kind of picked up, I would say really around the turn of the, well, I guess probably around 2000, but it really has taken it up until about, I don't know, maybe about 3 or 4 years ago to really pick up full steam. So it's kind of, it's a growing area for sure, and I think it's harder to pick up steam because we all come from our different disciplines. So, you know, I'll sometimes have conversations with people who are surgeons, who are dentists in a rural community setting in Arkansas. You know, there's someone that's, you know, halfway across the world doing all sorts of other stuff. So it kind of, it's a little bit disjointed, and I think that sometimes has prevented it from growing like the wildfire it deserves to.
Great, thank you. A question is, what about the National Institutes of Health? I think you mentioned on a slide that there was a study sections. Can people become reviewers to learn more about this area?
So I actually don't know how that works in terms of reviewers. I think how they operate that is that you have to have been funded by NIH before they'll tap you to be a reviewer, which I think is an interesting process. But you are eligible to apply for that sort of funding. And I think traditionally, I only know it from applying as an academic, but there are different sorts of mechanisms that you can apply for in terms of, I think there were 3 that I put on the slide here today, and they range from smaller and larger grants, but there are actually a lot of foundations that will fund this sort of work as well. So the NIH, has recognized that it's a certainly very important part of what they do, but it seems like a lot of people are diversifying their funding sources. So they'll take a little bit, they'll, test a little bit of their idea or test part of the adaptation with a certain part, a certain funding source, and then kind of build it that way. But it seems like sort of the non-traditional funders are really interested in this sort of work. And I think it's because it has such relevance within the community. So the NIH is certainly important, and I don't know that there is the opportunity to become a reviewer, but there certainly is the opportunity to apply for the funding part of that, not just at the NIH, which of course we want their money because it's a lot of money usually, but also think about partnering with some non-traditional folks as well. And there actually is one of the toolkits goes through what we call, I guess it's the 10 tips right now for applying for D&I research funding. So it'll walk you through kind of how to frame what you're talking about as D&I research to kind of create that sales pitch for grant funding.
Great, thank you. And for the attendees, I just want to remind them we'll be posting the video of this webinar in about 24 hours, hopefully, and that will have the slides so that you can get some of more of the resources. I know it went by a little bit quickly to be able to write it down, but we will have
those are all
webinar available
to go back later. Great, and I'm also happy to be in touch with anyone as well.
Great, thank you. The last question is, how did you get interested in this area?
That's a very good question. I don't know that I've had anyone ask me that before. So my background is in nutrition and physical activity research, and primarily I have worked with children from birth to 5 in kind of the settings and environments where I find them. So that's either at home with parents, or primarily most of my work has been within childcare settings. And D&I, because it has this kind of taking something that works and putting it into a new setting, inherently has a little bit of an organizational spin to it. And I think I was just getting so frustrated with feeling like I had to recreate the wheel every time I went into a new planning session or something like that. And I felt like we have all of this evidence that something works, and we're not really, most of us are sitting there just trying to think of new ideas. And that got really frustrating to me. And so I felt like, as I learned more about all the great work that other people had been doing, why not just take what others have developed and we know it works, over there in a different setting, and just kind of figure out how to make it work within the settings that I'm in. So I think it was really out of frustration that I found D&I science as kind of the solution to, making things more efficient and just a better use of everyone's time and resources. So it just seemed like a kind approach to research, I guess, in my mind.
Well, I can tell you from our view from tribal research, we really appreciate approaches like community-based participatory research and research approaches that value and require the community involvement, which is really great here. So anyway, that was our last question. So, and we're getting close to the end of the hour, so I'd first like to thank our speaker, Dr. Stephanie Mazzucca, for her very informative presentation and willingness to join us today. And we met you through our partnership with the Center for Diabetes Translation Research at Washington University at St. Louis. And there are opportunities through that center to get advice and consultation and help with the grants you're writing and with the research skills you might need. So I encourage people to go to the website and take a look at that, the Center for Diabetes Translation at Washington University in St. Louis. And we also have a link to that on our NCAI PRC website under Diabetes Translation. I'd like to thank everybody who joined us today. And don't forget to complete the feedback form that you'll receive in the follow-up email an hour after this webinar. And the webinar will be available soon on our YouTube channel that you can access from our website. Please feel free to send the link to the webinar recording to any of your colleagues who might be interested. And just 2 announcements before we leave today. Mark your calendars for this monthly webinar series. It's always on the 4th Thursday of the month, and watch for announcements for the next topic. And like I mentioned earlier, our May webinar might be the last Thursday of the month, but we'll let you know soon. And please save the date for our 13th Annual Tribal Leaders Scholar Forum to be held during the NCAI 2018 Mid-Year Conference in Kansas City, Missouri on Tuesday, June 5th, 2018. We'll be featuring several sessions where researchers will be presenting and interacting with tribal leaders, and we will also be planning a pre-conference session on Sunday, June 3rd. We hope to see all of you there. The pre-conference session, excuse me, just getting over my laryngitis. Our pre-conference session is featuring resources for tribal data capacity, data sovereignty, and the afternoon workshop will be an interactive session where we will play the new Tribal Research Future game that focuses on strengthening tribal academic research partnerships. Our Tribal Leader Scholar Forum, of course, features a full day session focused on data to inform tribal policy, including a plenary session, poster sessions, and several breakout sessions. You can find registration information for the NCAI Mid-Year Conference and the agendas on the NCAI website at www.ncai.org. Thank you so much for joining us today, and goodbye.